cardiac rehab when we are just trying to improve their cardiorespiratory system, okay? So when you get through like those lectures, there are 3 PowerPoints for Module 5 and 3 lectures. The first 2 lectures are pretty cut and dry. I did anatomy and physiology of the respiratory system in 27 minutes and medical management in like 16 minutes, so those are going to be pretty easy. And then you get to the third one, and that's about an hour, because everything that we're going to be discussing today is pretty much in that one, okay? So that is really the intervention part of it. So what we're going to practice in lab is that stuff, okay? So that's a longer one to get through, all right? So we're going to start today with auscultations, okay? And so that's listening to breath sounds. So you can see on the first page of our thing, it gives you where you want to be listening, okay? So we're going to practice that. Then we get into our chest PT techniques. So I've given you a handout to depict the different lung segments, okay? So talk a little bit about like secretions. What are secretions? Mucus, right? So how do we normally get rid of secretions in our lungs? Coughing. Most of us cough, and it's like you cough really hard, right? So these patients don't have the ability to cough, or it's not a strong cough production, or there may be contraindications to a cough, all right? So there's all sorts of things involved, like the manual techniques that we're going to learn are percussion and vibration. And part of it is knowing what lung segment you're working with, and then the position to put your patient in to help, okay? So that's in this handout too. And then you teach them breathing exercises, right? So this is pretty much your SCA, you guys. On your SCA, you've got to do lung auscultation. You're going to perform percussion and vibration with your patient in the appropriate position for that lung segment. Then you're going to teach them breathing exercises, okay? So that's pretty much how lab is going to go today. We're going to start at the beginning and we're going to work our way down, okay? And so it's a lot to kind of go over, but I at least want to introduce you guys to the topics, right? Because tomorrow when we break up the afternoon class, we're going to start into resistance. Monday I have you again, and we're going to talk resistance and progressing resistance exercise. And then on Wednesday, as I'm doing SCAs, then all of this is up for grabs for practice, right? We've got joint modes, we've got resistance, we've got vitals on the treadmill, and then you'll have chest PT stuff to be practicing. Yes, Cheyenne?
Did you say Monday you're doing SCA?
No, Wednesday.
Okay.
Mhm. Yeah. So almost, it's from here on out, the time that I have with you in lab is very limited because I'll be doing SCAs, okay? So the time that I have with you in lab, we need to move on to like new topics so that I can work with you with new topics. And then when I'm doing SCAs, it's up to you guys to practice with Ms. Johnson these skills, okay? And then if you can come on Fridays for open labs, I'm yours as well, okay? So it's just the way that it worked. Otherwise, you don't have enough time to practice. So like if Ms. Johnson and I were doing SCAs together and we split up the class time, like you're basically losing practice time, okay? So that's why I try to do it this way, so that you can get in the lab and you're still practicing, okay? But that means, you guys, that means you have to be practicing. You can't be in there chit-chatting and talking about other things. You've got to practice, okay? Because the skills get a little tougher from here on out. Range of motion was the easy one. Everything else is a little tougher, right? You've got to practice. And if you haven't tried getting on that treadmill, you need to get somebody on that treadmill because it's loud, okay? So you need to get used to that, all right? Any questions? Concerns? Comments? If you guys have filled out these charts and want to review them with me or send them to me, like you can. So this is the manual stretching one. You can see like the neck ones, like I bolded the ones that I would expect you to be able to tell me that's what you're stretching, okay? So if you want to double check and make sure that your mind is right, then we can look at them together. Everything else I tried to put just like the prime movers, okay? After you do yours, you can't just copy mine, right? Here it is. I thought I had it. Okay. I might make copies of this, you guys. These are breath sounds, okay? So as we go through the auscultation, these would be the different sounds that you would be listening for, okay? But basically, if you are hearing different sounds, then the air is not passing through that segment very well, okay? So it can be secretions, and if so, there are secretions, we're going to learn the techniques to help get rid of those secretions, okay? So I'll make a copy of this so you guys can have that and add that to your little packet too, okay? I thought they were in here.
So what we're discussing is what respiratory therapists typically focus on?
Yes.
Okay.
Mm-hmm. So if they are doing it, then you may not get to do this. I used to do it. I remember one time when Thomas and I started dating, I could feel it, like the congestion, like in my chest, and I hung myself over the bed, and I said, hey, right here, I need you to just like pound on it like this. And this was before he went to PT school, so he was like, what in the world? And I'm like hanging off of the edge of the bed with my arm up, and I'm like, right here. I'm like, just pound on it like this, you know? And so he was like, what? I said, I need it to move, you know, because like I wasn't able to like cough it up, and I could feel it sitting in there. So I'm like hanging off of the bed, and he was like, you're crazy. I said, no, treating myself. Because I don't want to feel bad, all right? So you bring seated, and what do we think about our seated patients? How high should the table be?
I like their feet touching the floor.
You would want them on the floor. Why do you want the feet up flat on the floor?
Stability.
Stability, they're more stable, right? Now, of course, when you go to the doctor's office, they make you hop up on the table and they don't adjust it. They don't have to adjust the tables, right? But if you are able to adjust it so that your patient is stable sitting on the edge of the table, right? If you're listening to someone's lungs because they're having issues, they can't breathe, they've got mucus, what kind of condition do you think they might be in?
Old, or what way?
They might be older, but also maybe fragile. What's another word that we could use? Weak or deconditioned, right? So if they're weak and deconditioned, they're elderly and fragile, do you think they've got good balance? Probably not. So you just want to be aware. Okay? Okay? All right. So when we look at our handouts, okay? Now, ideally, you're going to be listening to lungs through no layers of clothing or very thin layers of clothing, okay? So this sweatshirt is not ideal, but I'll just show you anyways, okay? Just to kind of demonstrate where we need to be, okay? All right, so she's sitting there. All right, so here's another thing, you guys. I gave you a couple pictures, and they look a little different, okay? But you want to just make sure you're almost hitting every lobe of the lung, okay? How many lobes of the lung do we have? 5 altogether, right? There's 3 on the right, 2 on the left. So when you look at the diagrams and the pictures, you can see they're basically just trying to outline the ribs, and they're following those ribs around, okay? Now, will you get points counted off? If you go too many, 1, like I'm going to go 1. So here I'm trying to get my upper lobes, okay? But here's her clavicle. Like I don't want to be on her clavicle. Can I hear anything on her clavicle? No, because I'm listening for the air moving through her bronchioles, okay? And into the alveoli. Said that correctly? Is that the plural? alveoli. Alveoli is the singular, I don't know what it is, right? So you want to be below her clavicle, and then you're coming this way, and you're listening. You're listening, right? So I'm looking like here's her end of her ribs. Do I want to come into her belly? What would I be hearing if I went into her belly?
Her digestion.
Her digestion, right? All of
Her
those
food grumblings.
intestinal sounds, okay? So you are trying to follow her ribs, so you can see that in the picture they're coming down, okay? And then we're gonna come to the side. So I did 1, 2, 3, 4, 5 on the front, okay? But you wanna hit upper lobe, and then you wanna come in here to like middle lobe. Well, that's not the middle lobe, that's middle lobe. And then there's at least 3, okay? So then you're coming in here, you have a shirt on, don't you?
That's what.
I got a sports bra. A sports bra, okay.
4 points to get all the low, but if you do an extra one, you're not hurting that.
Okay, all right, so you can see here, we want to go here, you want to get into here, we can go down here, and then we want to go this way, okay? So you can see you're following
backward
that
feet.
around, okay? On the back side, if we look at her back side, if you guys want to move around, okay? Same sort of thing, but now we almost follow the scapula. So we can go up here, and then we're following that medial border of the scapula down and around. Okay?
Like, are they normally breathing? We don't have to like.
Yes,
okay.
yes. Because that's what you're listening for. So
I hope they breathing.
they're
Oh
all
my
breathing
gosh, I
with
hope they
what you
breathing.
want to hear. So like as you are here, right? If I'm right here, all right, take a breath in,
Yeah, you know, like,
and then one more time,
I was holding my breath.
one more time, and breathe.
Yeah, whoever's gonna be my partner, really exaggerate.
So I asked her to do like 3 breaths up here because the first time I thought I heard something. But I think it was just her sports bra moving as she was breathing, right? So, you know, when you go to the doctor's office, they don't even let you fully exhale before they're moving around. So who knows what they're hearing or if they're just not expecting to hear anything, okay? Because that would be something too. Like I wouldn't expect to hear anything out of Alexia. And so that's why I was like, I'm sure you guys saw my eyes. My face is pretty expressive when I'm listening to things, right? And so I was like, what? Right? Because it wasn't what I was expecting. And so I took a little bit more time, let me focus in to hear if it was really just the air moving or if I could hear something else, okay? So as you listen to each other, like really kind of take the time. So at least you know. Well, I won't say that. When I did home health was probably the only time when I was like, oh man, I wish I remembered this a little bit better, okay? Because those were my patients that had congestive heart failure, COPD, they were really deconditioned, right? Sedentary patients. So if they were struggling with breathing and I would see their SO2 like stats go down, their oxygen saturation go down, then I would be like, oh man, like what's happening? And some of them you can hear the wheezing out of them, right? So if I was a good clinician, I probably would have done more. But you know, it's hard in home health sometimes. Okay, but so that's kind of how it is. Okay, all right. Questions?
So what exactly are we like supposed to hear? Just the...
Yes, you're gonna hear like it's really hard because when you listen to, I think it's the 3rd lecture, there are some videos where you can hear different breath sounds. I have that sheet of paper that I couldn't find it this morning, but I'll print it out and there's descriptions of kind of like what they are. So typically you're looking for like crackles or wheezes, okay? So like a wheeze is like a, and then a crackle, like you're like doing like the cellophane, right? Like you're balling up cellophane. is what it's gonna sound like as they're breathing.
What should it sound like normally? What should we hear?
You really won't hear anything. You can hear, like,
Like ocean?
it's not quite like an ocean, but you can kind of hear, like, some of it, but it's just
Okay.
it's just like something you can hear people breathing.
Inhale, exhale.
Yeah.
Inhale, exhale. Inhale more.
It depends on what it is.
Yeah, so there's a.
So the wheeze is more on the exhale, and the crackle is like more on the inhale.
Okay.
Mhm. Okay, so it just kind of depends. But as you're listening to your classmates, hopefully, like, it just kind of, you can tell.
But you need to know what.
Okay.
Okay.
All right. Okay. Yes.
Yeah.
And my husband was in school, for some reason, he thought it was very important that I learned the chest sounds. He was always like, you gotta listen to this with me.
It is, but you know, like, my whole time I was in outpatient, like, not at all. Because the pulmonary patients that came in for pulmonary rehab, they worked with a respiratory therapist. So, like, we didn't get to do any of it. So, but it's part of what we do. It's within our scope of practice. So, here we are.
Field trips. My brother was just talking about my lungs feel weird. My mom was like, "Can you listen to his breathing?" And I was like, "I don't know how to do that. That's not something I can learn how to do. I don't think I will do that." That was literally Monday.
You can go home and do it. But this would be important, like you said, home health.
Home health, even when you're in the hospital, because if you are trying to walk with your patient and their breathing really becomes labored, you start hearing all sorts of things, you may have them sit down, pull out your stethoscope and listen, and then you can report back to the PT and say, hey, this is what I noticed when I was walking today. Is it possible that we can try to get someone else in? If they don't want PT and PTAs to do it because they have a respiratory therapist staff, then they need a referral to come in and see that patient, right? So your job at that point would be, okay, am I paying attention? Do I know enough to maybe see if we need to get a different referral in, right? Does that make sense? So you may not actually do the treatments that we're going to be learning today, but at least you're aware enough to say, hey, I think we've got an issue going on here. And then they can pull in respiratory therapists. They can do more of whatever they evaluate and put them on the inspirometer. I don't know. Most people are on inspirometers in the hospital, aren't they? They get admitted into the hospital.
How about like a pulse ox?
Like the little breathing, like inspirometer, like
Oh.
yeah.
Yeah, I think everyone gets handed one upon admission. Yeah.
Because it helps to decrease pneumonia. Because they're laying into the breathing. Okay, so you've got to differentiate between the two.
Very quiet.
In the front and the back.
Mm-hmm.
Very fast. You know, you did it fast and you bring it along.
Stethoscope.
Right now I'm going to show you the techniques. We're not going to worry about positioning. Right now we're just going to practice how to do these techniques, okay? So these techniques are percussion and vibration. So if I can have someone be a patient for me. Who wants to be a patient?
I'll be a patient. Can you?
Okay, let me preference this with I need to be on skin.
Somebody that can.
So someone who does not mind exposing skin.
No, I can call. Never mind. I forgot what I had to do.
Yeah.
You're gonna lay down. We'll put your head down here.
Yep.
And you're gonna lay on your stomach. Is the table cold?
No.
Okay. All right. I want to put this under your feet for a moment. Okay. Are you okay with your head like that?
Yep. Y'all good?
All right. I'm gonna raise you up. Don't fall off.
Do it, don't.
Don't. Don't. Oh man, look at my pants now. Yeah, but these pillowcases, not my own sweatshirt. Okay. All right, so you guys might want to come on this side because this is where I'm going to stand, okay? So the first one is called percussion. When I say percussion, what does that make you think of?
Like drum.
Like a drum, okay? So that's exactly what we are going to do, okay? So when you do this technique, all right, you want to make sure your hands are cupped, okay? We don't want flat hands because flat hands will result in slapping your patient, okay? A cupped hand, like this, Jordan, okay, will create kind of like a galloping horse sound. That's what you want, okay? So when you are practicing this technique, there you go, okay?
Where do you,
All right.
do you do it like over the area?
You would do it over the area that needs to be drained, okay? So when you do this, ideally, you would know which segment needs to be drained. You would put them in the position that corresponds to help that, right? Because the position you put them in is going to use gravity to help pull the secretions out while you break it up with your percussion, okay?
And this would be chest PT,
Chest
not
PT,
pulmonary.
not pulmonary PT. This would be chest PT. You may see it as like airway clearance and different things like that too, right? So this is our manual chest PT. We are draining secretions, helping drain secretions, okay? So you're gonna do percussion,
You okay?
okay? If I have a flat hand, listen to the sound, okay? Right? You can hear a clear difference in the sound, and she can probably tell you there's a clear difference in how it feels, okay? So,
I get it.
so as you practice and as I walk around, that's what I'm listening for, okay? Is, do you have a gallop? Does it sound like a horse? And I like to end like that with a flourish. Boom, right? Like I'm playing the drums.
Speed or-
You do want it to, it doesn't say like a certain speed, but you do kind of want to alternate. It's not, okay? It really is more like that gallop, okay? Okay? And the other thing too is like I keep my wrists straight, neutral, and I'm not going up and down. Okay.
Is it
You have
for a
the key?
certain
Yeah.
amount of time, like, how long do you?
3 to 5 minutes.
Like constant?
Yes.
3 to 5 minutes?
3 to 5 minutes. Okay. But you're keeping your wrists in neutral, right? So when I do this, my wrists are not going into flexion and extension. I'm not doing this. I can't even keep a rhythm, right? So my wrists are neutral and it's coming from my elbow, my
Yeah.
forearms.
So body position is very important for that 3 to 5 minutes.
Yes. And some of it too, like when she's positioned differently and stuff like that, like you'll have to adjust, right? Okay. And then pretty much once you're done with percussion, you go right into vibration. So if I'm working on this area, I've done my percussion, and then I'm going to go into vibration. All right, Jordan, I need you to take a deep breath in, and then exhale. And inhale, and exhale. And inhale, and exhale. Okay?
Interesting. How long do you do that for?
Like breaths, it's breaths. 7 breaths? 7? Okay?
So you coming down on her exhale. So she's up top,
So
come
as
down
she
with
is
her.
exhaling, I'm vibrating. Okay,
go
so
down
think
with
of it as I want to do percussion to break up the secretions. I want to do vibrations to shake them out.
Got
So
it.
you
Okay.
do that like whole process like a few times, so like percussion, 5 minutes.
So the way that I would do it is I would position her, I would do my percussion, I would do my vibration, I would teach her a cough or a huff, okay? And then I would leave her there to see if she can spit it up. And then I would have my spit cup ready. And then, okay, you feel okay? We're gonna try it again because we didn't get anything to come up. So we're gonna try it again. And then I'll go through that process. So you go through all of that and then let's get it up.
Spit something up, you're good to stop, or it depends on how much there
It depends
is?
on how much it is and depends on kind of like how they feel, right? Because I mean, you don't know how much is stuck in there, but you want to make sure that you're trying to get as much out as possible, right?
Would you like re-listen for the sound again? Okay.
Yes, because if you've cleared secretions good enough, you may not hear any sounds.
Mm.
Yeah.
Mm-hmm.
Right.
Listen, every time I say yeah, now you guys, my kids are listening to like Party Like a Rock Star on like Kids Bop. And yes, we do Kids Bop, right?
Oh,
And
jeez.
so they're like, yeah, party like a rock star. Or party like a rock. Party. And now my 2-year-old is like, party like a rock. Yeah. He goes, yeah. So now I can't help it. Now I say yeah and I have to say it like that. Right?
They're so bad.
They are funny.
There's some weird kids pop.
Yes, there are. Yes. I'm like,
This
what?
has been taken off the list.
Like, if your kid really wants to listen to it that bad, you got issues. Like, you might as well just let them at that point.
Well,
Or just block
anyways.
it off.
Anyways, so that's, that's our morning routine. We all party on the way to school. So.
I have no children.
Um,
I have no son.
Questions about this. So right now, what I want you guys to practice are percussion and vibration, and then we'll kind of put it in together with positioning, okay? The other thing, when we get into positioning, okay, which lobe or area, like think anatomically, would I be working on here? Posterior. Does someone say posterior? Okay. So it's a posterior lobe. All right. What other segments of the lobe do we have? Upper and lower. What else? If we have a posterior, we have
Anterior.
anterior. Okay. So you may have issues anteriorly.
Oh no.
Yes.
What?
Okay. So this is when you guys have to be.
Holy shit. Where'd you go? What do you do there?
You ready? Are you okay if I demonstrate on you?
Oh.
Let's do, Sheldon, can you get her a gown? Let's get her a gown.
Yeah, you do it yourself. This is how you do it.
No, hey, but remember, why do we have to do percussion and vibration with a patient?
They gotta break
They
it up.
can't cough, they can't remove that secretion. So if they can't do that, sometimes they don't have the ability to do anything.
Yeah.
Think of your high cervical spinal cord patients. We haven't gotten there yet, but you guys, what innervates the diaphragm?
Hmm.
What innervates the diaphragm? See, 3, 4, 5 keeps you alive.
Mm.
S2, 3, 4 keeps the pee off the floor.
Mm.
What?
Oh, that's cute.
Can you write these down?
Wait. Nerves? Those were nerves.
Those are your nerve roots.
Oh.
See, 3, 4, and 5 keep you alive. Goes to your diaphragm. Your diaphragm doesn't work, you're not breathing.
That's it. here,
Your
right?
diaphragm is your primary respiratory muscle. Everything else is secondary or an accessory muscle. You lose your diaphragm, you are struggling. Okay? Your cervical spinal cord patients have difficulty with secretions, removing secretions. So you're doing it, then you may be teaching family members how to do it. In that second lecture, it goes over suction and how to suction a patient. I don't teach you how to suction a patient, but it's there. You may be asked questions about it because, again, your spinal cord patients may need to be suctioned.
Like a baby?
So you go in their trach or down, like their their trach, or orally. You go down, you get that tube into that lung, and you suction the secretions out.
Mm.
It's like the nose sucker boogers
I
for
had
children.
no clue that we could do
That we can do that. Some of that too, depending on the patient. Again, you're doing it initially, and then you've got to teach caregivers, family members, because they'll be discharged home to their family members, right? There was somebody. There was a commentator. His son. I can't remember what happened to his son, but he was missing games because I think his son was reaching the end of his life, and he was talking about how like he had to suction him like 3 or 4 times a day.
Like we would suck out trachs at work after we changed them, but it's just a long catheter with like a little thumb. You just stick it in and
stick it in
hold your
there.
thumb and suck it
Yeah.
out. Like that was
Is that the similar to the thing? Because with my father-in-law, I used to have to suction out his, he couldn't swallow. And so is that a similar type of device?
Well, what were you suctioning?
He couldn't swallow his saliva and all that, so I was
Oh, okay.
suction when he would get a little
Yeah,
going on.
kind of.
Okay.
But that one is because it was like pooling there. This is you're trying to get out of the lungs.
So go this way instead of that way.
So
Okay.
then you just basically like take the tube and shove it down their throat. Get it out.
Like you can,
Okay.
right? But again, what might be different too is if you know a certain lobe that you're trying to get into. But like when you watch the video, there is a video. I believe it's a video. That I attach where she kind of walks you through the process,
Okay.
and she marks how far like you would stick the tube in and stuff like that, right? But that's suctioning. I don't teach you suctioning, but it's one of your learning objectives about understanding suctioning. So there it is. Okay. So it's there. All right. So Jordan, sit up for a moment. Let's put your gown on. If you have patients that are well endowed, that's a nice word, then offering them a gown can be very helpful too, okay? And at least that way, again, you want to try to be on the skin when you do these techniques, especially like the vibration, because otherwise you might just be moving clothing and then you're not really doing anything. Okay, but at least what you can do, it's going to act as like a sheet or a drape, and then you can expose the area that you need instead of having her whole chest out while she's laying on the table. All right, so you can lay on your back. Well, you know, some of the hospital gowns are a little thicker, right? But at least this way, if I needed to get to her, then I can expose this part, okay? And then everything else is covered. Okay, her belly's covered, the rest of her chest is covered. So this is one thing too, you guys, like depending on the size of my patient, I may only use one hand instead of both hands, okay? Because if I want to do this upper segment up here, okay, then this is how much room I have, okay? And look, I'm already on her shoulder. Do I want to press her shoulder? No, so like I want to get in here and I can do this. The other thing I can ask her is, Jordan, do you mind if we just take your hand, we're going to put it right here on your chest, and can you just pull that tissue down? Thank you. And then I'm going to be right here. And then my vibration, breathe in and exhale. And breathe in and exhale. Breathe in and exhale. Okay? And then turn your head this way and cough. Right? And hopefully there's a spit cup right there, okay? That she can go ahead and spit.
Why'd you ever turn towards you?
Well, because it was on the edge right here. And this is what happened.
So either way.
Well, yeah, but you also saw like I kind of stepped away. So I don't want to get coughed on or anything like that, right? You could have her turn that way too. I don't think it really matters.
Okay. I just didn't know if there was a reasoning in turning.
Right? But really too, you guys, if I was really like you're when you look at these pictures here, when we start looking at the positioning, it gives you what the branches look like. Okay? So on this one, the upper lobes, the anterior segments, you can kind of see where they are, and this is the picture that he's in. So he wants to be this way, right? Because then now the bronchioles are coming up this way. Okay? So if I'm sitting up, okay, if I want to go anterior, I've got coming up this way, and then they're going to shoot out this way. Okay? Does that make sense? So now if I'm trying to drain one of these tubes, I want to be supine, so gravity is pulling this way. Okay? Does that make sense? Feel like alien. Because you want to pull it from the smaller tubes where it's getting stuck and get it into the bigger tubes, get it into your bronchi. Okay? And then they can cough it up. Okay, does that make sense? So that's why the positioning is important, because you're trying to get those bronchioles and the way that they are sitting and going to the lung segment to be in a dependent position so that they're going to drain into the larger tubes. Okay? Because if not, like, they're not going anywhere. Okay? Does that make sense? But right now, okay, I will tell you it's easier to practice on the back. Or if your patient is in sideline, if you want to turn that way.
So the charts let you know like where the drainage is supposed to be?
Yes, usually, right? Because if your supervising PT was any good, they would have done auscultations and notated where breath sounds were, like what was going on. If you're suspecting like pneumonia and different things, there may be some chest x-rays that will confirm like we've got issues here, or even if they have the crackles and things, you may have imaging to confirm where it is, okay? So the other thing too, like this is usually a good place to practice. You can usually get your hands in this area pretty good, okay? So right now I just want you guys to practice your technique. Don't worry about proper positioning yet. I just want you to practice the techniques, okay? Get that sound down, get that gallop, and then vibration, breathe in and exhale. Okay, when you do a vibration, it's like a shake. I'm not doing this. Okay, this is not vibration. This will give you a 0 on that SCA. Okay, well, I mean, like, look, my head is like going everywhere too. You're here and it's shaking, vibrating here, back and forth, shake, shake, shake. Okay. All right. All righty. All right. Let's keep working. Two, when you've got two hands on them and you're doing vibration, they're going together. They're not going alternating like our percussion. They are going together. You're not doing this and creating friction. You're having two hands creating that vibration force to try to move that mucus. Okay? All right? Yes. Right? So, burn fracture, osteoporosis. Some of it too, you know, you guys, is going to be how if they can be prone or not. In that PowerPoint, there's like 20 different like contraindications.
Oh.
Because it goes through all of the different systems. Just think of the big one. Fracture, osteoporosis, like open wounds, like some of those things. So as we kind of look at it, I can't think of what they are, but it talks about like more specific kind of like acute like respiratory diagnoses and things like that.
So like a patient that has like really bad
You know, for me, if you know where they are, if they're in ICU, the respiratory problem will be a lot of percussion because they have so many tubes in them. You know,
That's
things
true.
Like that.
But I would say too, though, it might just be easier to suction them than to do all of this.
Because you're not going to have the patient to do the breathing, to do the vibrations, so you can't do the whole cycle.
But if they're just in the hospital and they have pneumonia, then
Because I feel like they went through and did this with COVID people. Did they not?
I don't think they did it specifically like percussion and vibration, but what they did was a lot of prone positioning.
Yeah.
Oh, they just flipped them.
And the APTA, I told y'all, they have a lot of good little quick 30 minutes or 2 hour little things on COVID treatment, because y'all are going to be going to environments where you're going to be not seeing active COVID patients, but you're going to have patients that have the residual effects of what COVID did.
And with the long haulers?
The long haulers, or even just people that are recovering. I mean, they're not actually positive with COVID or can transmit it to you, but you got to deal with their limitations.
Still experiencing
But
symptoms.
like if you look at how like those patients were affected by COVID, it was more like capillary gas exchange type of things, not so much that they were getting fluid stuck in their lungs.
It can be more
It
the pulmonary
was the
stuff.
gas exchange that they weren't getting.
Oh,
Right.
okay.
And I'm seeing patients
Because
with
of
more,
capillary dysfunction, not like they couldn't get air in,
yeah.
right?
I just know a lot of people are saying too, like after you've had COVID, like just a simple cold afterwards is going straight to pneumonia and just.
Yeah, the system is compromised. I have patients that have had COVID last year when it happened, and they're still dealing with in and out of the hospital with pneumonia. I have several.
Yeah.
It's like the tiniest thing just sets them off, and
Alright,
it's.
get out your pumping. Don't sit.
All right,
Don't
so
sit
did
too much.
everybody practice?
Yes, ma'am.
Everybody had a chance for me or Miss Johnson to come by and, you know, tell you how you're doing.
And they did say that it was tiring to go past the minute.
Miss Johnson, Miss Johnson, Brittany hasn't had anybody watch you yet.
Okay,
Can you scoot a little bit closer for me?
Okay? All right, so this is what I want you guys to do, okay, with your partner. I want you to position your partner so that you can clear the posterior basal segment of the lower lobe. Posterior basal segment of the lower lobe. Okay?
Posterior basal. Lower lobe, posterior basal. Okay.
Under hips and under stomach.
And you can put a pillow, hike you up.
Okay, so where do you want the situation to go up?
You want me to do it to you? So you can manipulate it?
Yeah.
How you gonna position it? You said left, right?
I didn't say you
You
put
just
them
said
in a
post.
position.
Yeah, put them in position.
Put them in that position. Because I'm telling you right now, it won't matter for this one.
The table's supposed to be up.
The best that you can. Okay?
Come down a little bit. Well, we can bring it up.
In the ideal setting, if you needed other things, you would have both.
And then your hands come up by your face.
So now, these two tables, you guys do the best that you can here. Because there's no way to really elevate the legs. Everybody else, hopefully you can get those tables up. Now, even with the tables where you're putting their legs up, it's still not ideal because it's kind of putting your patient in this weird, awkward position. No, do it. Okay? So then now, why do you want your patient in that position where their head is kind of coming down?
Because you want to be able to get it up.
Right? Because now, remember, right? So this is the posterior basal segment. When you look on your other sheet, you guys, where is the posterior basal segment located? Right? It's at the bottom of the ribs, medial aspects. Okay? Yes. So on your patient, here would be, this is about where your posterior basal segments are. Okay? So if this is where the posterior basal segment is, which direction are those bronchioles going? They are coming out this way, like this. Okay? So in this position, you can see they're going to drain that way. Right? Does that make sense? Sort of? Sort of.
It seems like all of them are good. Like, it seems like almost every position would be better to have them sort of down.
Down a little bit unless you're talking about upper lobes. Yes, because
Because
upper
they
lobes
like
they're
come
going to go.
down and then, gotcha.
Okay? So, most of the time, like what Cheyenne just said, it kind of makes sense, right? If you're working anywhere in the back, it would be nice, one, that they are prone, and then that they are a little bit inverted. Would be nice, to the best of your ability. Okay? So on these tables, they're trying to shove pillows and things underneath them to try to get a little bit of that inverted position. Because you want to work on these segments, okay? If I was doing left posterior basilar segment, then I would do my treatment here. Okay? on this side, do my vibration and cough. Okay?
Could you describe the lungs and how they're coming out again? I missed that.
Yes, like that.
Okay.
Okay? Listen, I tried to use pipe cleaners and all sorts of things to try to help. I can never get it to the way that I like it. But that's what you want to think about, right? Right? Because what is the anatomy?
There you go, you okay?
What is the anatomy, if you can remember, of our lungs going towards our segments? When you breathe air in, where does it go?
Do they branch off like right here?
Yes, but what tube does it go in first?
The pharynx.
The trachea. It does go through the pharynx because that's going to be up higher, right? And then you've got the trachea coming down. Once you get into the chest cavity, then it branches off into the bronchi, and then it branches into the
Alveoli.
not yet
Oh,
bronchioles.
alveoles.
Is that what you said? I didn't hear you. I'm sorry. I heard alveola. I kept hearing of that. Right at the end of the
Bronchioles.
bronchioles, we have the
Alveoli.
alveoli. That is where the gas exchange is happening in the alveoli. All right. Mucus can get stuck in the alveoli. It can get stuck in the bronchioles, especially in those terminal branches, because they get smaller and smaller and smaller until they get to those alveoli. Okay. So theoretically, that's where you're going to have issues, is in the smaller bronchioles. And so what you're trying to do is move them into the bigger tubes so that they can be removed from the body.
So you're trying to have it go back the way it came?
Yes.
Okay.
Okay, so then now when we talk about which way are the bronchioles going to this posterior segment, you think, okay, here's like the trachea, here's the bronchi, and then the bronchioles are coming this way, right? Here's posterior, they're going to be coming this way. So to get them from here to here, you got to put them this way,
Okay.
right? Does that make sense? So yes, the easy way is memorize that sheet of all those 9 positions so that on your SCA, when you're told to remove secretions from this certain lobe, you know what to do. But really, like, this is understanding what's happening. Why? This is why we do it. So if you have to explain to somebody why you want them in that position, you know why. You can tell me why. Right? Because on that practical exam, it says explain your rationale why you chose that intervention. This would be the reason why we chose this intervention and this position. Does that make sense? Right? Then it asks you to explain why that or how that intervention will help. Okay? Same for this one, it's the same thing. You're getting things to drain. You're using gravity to help you. Okay? If you look at my horrible drawings on the whiteboard over there, Shayna asked me, why are we doing vibration? Okay? So the first one, if it really is like this, I have no idea, you guys, but this is how I get it into my head. Okay? So in this first one, you've got mucus stuck to the walls of the bronchioles. We're going to do percussion where we are pounding on them to break it up. So now it looks like this. It's free floating in our bronchioles. Then we do our vibrations to shake with the idea that we want to shake it out of the tubes. Get it into the bigger tube, and then gravity's going to help bring it out. And then you ask them to huff or cough to spit it up.
Okay.
Do we see that process now? This is what's happening. In my head, this is what I tell myself is happening. Okay? If it truly works that way, I have no idea. But in my head, that makes sense. This is the reason why I do percussion, I do vibration, I position them, and then I make them cough. Okay? Does that make sense? Okay. All right, let's try another one. Okay? All right, so clinicians, position your patient to do the upper lobe the posterior segments of the upper lobes.
There you go.
I'm just gonna sit on the side of the table and hug a pillow.
Lay down.
Oh, okay.
Yeah, lay down.
Are you comfortable?
Okay, there we go.
You got
I said upper lobe, posterior segments of the upper lobes. So hang on a second. All right, so Patrice was good. You guys, she had her patient positioned, and then she started doing percussion like down here. Up and down, up and down. If I'm right here, what lobe am I working on? Well, actually on this left side. The left side, this might be is posterior. Well, posterior would be here. On the left side. On the right side, posterior is up here. Okay?
because on your left side.
You see it? Here's posterior on the left. Here's posterior on the right. Okay, so posterior is shoved way over here. Okay? So, when you go through this, yes, you can memorize, but the other thing too, on your SCA, if you start to do percussion down here and you're supposed to be doing posterior lobes, I'm going to be like, your treatment is ineffective because you're not in the right place.
Yeah. This is the spot again here?
On the left side, it's going to be like more right out here. This is still considered apical according to this diagram.
So here.
Yeah, look at the diagram sheet.
I
Okay?
did, I was trying to find the spot, it's right here.
Yeah.
So, okay, this is the lung, like that.
Yeah, so you're going to think the lung is here, okay?
So do we just focus on one side or do we do both sides? Even if it's, you know.
So if she has issues, if your patient right now has issues on both sides, I would do one at a time. I would do one at a time because then I can focus and concentrate on one side, and then I can go to the other.
And that means you want to do the whole segment as far as get them the cough,
Yes.
whole sequence.
Okay.
Good job.
Okay. Does that make sense? Because the little picture. Anterior basal segment of the right lower lobe. Right anterior basal segment.
You're gonna lay on your left side.
Well, right anterior basal segment would not be an upper lobe. Right anterior basal
No, we need
segment.
this.
We don't have a, sorry, Sheldon.
Your.
Yeah, Sheldon, just lift it
I
up
don't
on
know
the
your
table.
No, I'm gonna work on your right side. So you're gonna lay on your right side. So this one's gonna go under your left. This one goes under your head. This arm goes with your body. Put that one with your body. This one. No, in your arm. No. Let it lay down.
Okay.
And then this goes
Okay,
out. And then raise. And we would raise you way up high, but I can't do that. And lay it more on your side. Yep, let this arm basically go with you, and you're gonna be on your side. And now just scoot that
I'm gonna
towards
put your leg, your pillow a long way. That way you support your whole leg.
And then this arm just goes over your head. I'll make you taller.
Hello, this is stuff.
Oh, he's after lunch? Oh, yeah, after lunch, yeah.
Oh, I forgot about you. Yeah. Here today. Yeah.
Okay, So you guys are after the right anterior basal lobe. So if you want to drain the right lobe, what side should they be laying on? The left side.
Oh, you're laying your
Right? So you guys all got that? If you want to drain the right lobe, they have to be laying on their left side. So you guys need to switch. Okay? So then now, you guys tell me, where is the right anterior basal segment?
Okay, so we're not really looking at what they're targeting on the picture.
No,
we're
because
coming
it's-
back to the other
Because it's
one.
really hard to tell in that picture.
Okay.
Because really, like, what's the difference between the lateral basal and then when you start looking at the lateral? So you've got anterior basal and lateral basal, and they look like they're in the same place. Okay. All right.
If we
So
really had to
where
do
is
this with a
that
patient,
anterior
we put more
basal
pillows,
segment?
right? Because we
Yeah.
don't have a good
It would
angle.
be like this.
Even
Yes.
more pillows,
Yeah.
like I would have
Yes.
like 10
So
pillows if I had
you
them.
really need those legs up more. Right? Okay, so if you guys looked at the picture, the right anterior basal lobe is pretty much at the very bottom of that lobe. Okay? So just because they're in this position doesn't mean that we're doing our treatment up here. Right? It's not up here because this is not the anterior basal segment up here, close to his armpit. It's towards the bottom of that rib. Okay? So if you've got long ribs and a short little torso, your pelvis may be here and your rib may be here, and this is where you are. Because that's where that segment of that lung is. If you've got a longer torso, it may seem like you're way up here, but if that's the bottom of your ribs, that's the bottom of your lungs. Does that make sense? Because you want to get on the right segment of that lung. All right, go ahead and try a little bit of percussion there.
Take a breath in.
Yeah.
And breathe out.
So here's like the end of her ribs. This is where you would be. Okay? Sounds good down here. Chariot is coming. Chariot's coming. And then vibration.
Take a deep breath in. Deep breath in.
Good job.
All right, we good? Yeah. All right.
And sputum.
All right, so then the next one, clinicians, position your patient to do the apical segments of the upper lobe. And then we'll do treatment on the right side. Oh, you just on the right side. Let's switch it. We'll do the left side. All right, so we're going to do apical segments. Left apical segment of the upper lobe.
Well, you're like sitting, and we can't really do that. So hold it, don't fall. Oh yeah. Atypical segments, upper lobe. I can't remember if she said left or right.
Left.
Left.
Left apical lobe. I don't know, can you? What position, where are you going to be doing your treatment? Okay?
Does this matter for a long time?
I don't think it matters. Because again, if your patient's in the hospital, are you gonna transfer them over into a chair? Maybe, maybe not. Right? You might have them there, okay? So then when you look at where that apical segment is, okay? Right? So I said the apical segments of the upper lobes. You've got an anterior and a posterior segment, all right? So now, how would you do your percussion on your patient? It just says apical. Is it right here? So it's kind of more like on top, right? So apical is like on top. So those of you that are in on these tables, if you're using these tables, okay, so with these ones, you guys, in the picture, they're not leaning forward. They're not leaning forward. They're sitting up, right? Because if you're thinking apical segments, what does apical mean? Top. What does basilar mean? Bottom, right? So you want to think we've got the top of the lung now. Which way are bronchioles pointed on our top ones? They're going up this way. So you want your patient to be sitting up so it drains down this way, right? Whereas when we talked about basilar a minute ago, they're oriented this way. If I'm upright, they're oriented this way. So I got to get them inverted to drain those bronchioles.
What's gonna stop things from draining from up here down into the lower?
Nothing. Nothing. Hopefully you do your treatments and make them cough before it starts to settle down there. Right? But then also too, you guys, like, if you're worried about how it's going to drain, then typically you wouldn't have them sitting upright for a long time, which means what then? They're laying down. Well, but they're laying down.
You do treatment and move them?
You can move them. Make sure that they don't sit there all day. Because then as things continue to drain, then if they aren't able to cough them up very well, then Cheyenne is right. It could possibly seep into your lower ones, okay?
Do you typically fill up the top first and work your way down, or it just doesn't matter?
It just depends on where they're having their issues, okay? And where it's stuck. So if you're doing, oh, I said left, didn't I, right? So you can position yourself. So if I was over here, I'm thinking I'm at the top, so I can do my treatments this way, okay? And it may be one of those things that I can only get one hand in there because I can't do this very well. And typically the nice thing too is this usually is not a big area I have to work on. I can probably get it pretty good with my one. Now I say that, now it's like I can't percuss. Okay, does that make sense?
Alright, when you go for
Okay.
a type, come back.
That's smart, that's patient education.
Patient education.
So you want to make sure that you're still cupping, right? And when you are doing percussion, what is landing, whether it's going to be on the top part where your shoulder naturally curves, you're still focusing, I'm going on this outer rim of this cup I have made. So even when you're on this surface, can you put your arm down please, sir? Thank you. When you're on this surface, that's all I want to feel, is still this, not molding to, right? Can you guys hear how that sounds different? Can you hear that? Does that feel different, Andrew? Yes, right? Because those turned into slaps. Because my hand is basically flat against his surface, right? Okay, does that make sense? Okay. All right, so I've brought up huffing and coughing a lot this morning, okay? What's the difference between a huff and a cough?
Aren't you trying to heave it out when you?
Kind of, right? But really, you guys, when you huff, okay? All right, so right now, I want you guys to all try to cough like you're trying to cough something up out of your lungs. Those of you that have the mask on, you probably feel good, right? Right? What do you feel working? What do you feel working when you do that?
The diaphragm?
Diaphragm and what else? Abs. Sheldon's working his neck muscles. All right, so we've got some work to do with Sheldon because he's not even using what he can to forcefully expel anything. Right? All of our own little like
I mean,
quirks.
like, when you're sick with, like, bronchitis, your abs always hurt, 'cause that's what
Because
you're
you're
doing.
using your abs to try to force it
So you
out.
have neck pain then, right?
Usually an inhale first, right?
A little bit, yes, because you're trying to like almost like build it up, and then you're gonna contract those abs really fast, like, oh, right? Okay, now your huff, supposedly, should be less, right? So think about, you want to fog up a mirror, so you've got a mirror in front of you. It's not even that hard.
Doing it fast.
Like you're going to blow someone's house.
That's
Can I
just,
get anything up?
so that's just throwing.
You can. Why would you need to do a huff with a patient and not a cough?
If they're weak.
It's their stomach, they can't do it.
So one, if they're weak, but what else?
They're irritated.
What if it's there?
Okay.
And
Possibly,
the
right?
It's right there.
They may have some abdominal issues. What else? Have you guys looked at pain where? Maybe, right?
Or anywhere
What do you
down
think about
here.
your patients that have just had open heart surgery?
Oh, their sternum just got wired back.
Do you want them using all of that force to be able to help maybe move secretions? Right? Because you're going to put that force on them, and what's going to happen? Yes. Okay? Now, they are also taught to brace themselves if they have to cough. But if you can teach them to, then they can still bring it up. If you've done a good job moving secretions and it's right there, a huff can still work. The cough is when they're trying to get it from those bronchioles and they need that force
Are
to
you
get it
doing
up.
a lot of this like the post cardiac? I'm just
I
thinking
don't,
like they can't lay in
you
some of
wouldn't
this
be doing,
position.
well, one, they wouldn't be able to lay that in those positions, and then you would treat it like a fracture because they cracked the sternum open, so you wouldn't be doing percussion and vibration with them, but they may still need to remove secretions.
So how would you do that?
Teach them to huff,
Just to have.
right? But when you teach open heart patients to move, usually they're bracing themselves, right? So if you've ever known anybody on the cardiac ward, they get those nice little heart pillows sometimes. Nice places will give them heart pillows. And so they hug those pillows when they move, right? Because how would you get a patient who's just had their sternum cracked open, how would you get them out of bed? What are ways that we can get patients out of bed?
I mean, if he's in a hospital bed, we can elevate the bed to more like a long sitting position.
Okay.
And then we're just moving his legs over.
Okay, so that's the easy way.
Let's
Mhm.
go with that.
What's
Okay.
a log roll?
But how long are they going to be in the hospital? And then when would he be going home? And you would have to make sure he can get out of bed at home.
How long do the restrictions on like pulling with arms last?
How long do you want him to rest because they've just cracked open the sternum, and if you treat it like a fracture, what's your healing timeline for
3 to 5
fractures?
weeks. So still 3 to 5
Yeah,
weeks,
full
they're
time.
bracing her. Wow.
Mhm.
Then you got lift in
So
the
then he
car.
has to roll.
He
get
has
into
to
love.
roll.
There's not an option.
Because if he's not in a hospital bed at home, he has to roll. What kind of roll are we gonna do? A log roll while they're hugging their pillow. They're bracing, right? So that's why some of them you'll see, it is a nice little heart pillow that they get on that cardiac ward, so that they know they have to hug their heart pillow, right? If not, you give them a pillow and you teach them to log roll. Because if they come up into a long sit, again, what are we using to get up into a long sit? Abs. So then you're getting all of that pressure from your abs.
They're able to push up once they're like on the side or.
Yeah.
I mean, we're in this position.
Yes,
That's why.
but sometimes too, I would say depending on their weight, because they'll have restrictions on how much pressure they can push through their
If
arms.
they're pushing through their arm, they're contracting pectoralis major, which attaches to the sternum.
So would we decide to keep them in this position and sit them up? They're gonna have to have a fan.
Sounds like
When
that'd be
you
really
fall in
fun,
that
yeah.
position, how you gonna transfer them?
That's a lot.
Yeah. That's treating your patient.
No, I just, not even for us, like after, once they've left and having to do that.
Sure, a lot of them like go home to a recliner straight away.
Yeah, they
So
do.
that they don't have to. 'Cause
then you're
I think
asking
that's
someone else
what
to
I
be
did.
out
Went to a
and
clinic.
at home, and then for somebody to be there to help you, like that's.
Maybe, but let's think about that. Let's think about that for a moment too. Okay? So she said her brother went home to a recliner. So how would you get up out of that recliner?
You're push.
Still gotta push out.
Yeah,
Pushing
rock
through,
it.
you're pushing through your arms,
Yeah.
right? So unless their lower extremity is strong enough to get them out of that soft, low seat of a recliner,
They gotta scoot up to the edge of it.
they have to push through their arms to get them up out of that chair.
But even then, if they just got open, they're so weak. Like that's such a hard recovery. Like
They're
don't
gonna
have
need
the strength to do
assistance.
Right? Because
Sometimes,
why
too,
do
if
they
they
have
have it.
open heart surgery? Why would they have open heart surgery?
a valve
Could be a
replacement.
cardio.
Could be a valve replacement.
pulmonary. No cardio.
If they're like a cabbage, cabbage don't they open them?
Yes.
Yeah.
So what's a cabbage?
Coronary artery bypass.
Graft.
Graft.
Right? So remember the cabbage, right, you guys? So
I got 3.
the artery, like you have the aorta leaves the heart to send blood to the body. There's also an artery that's right off of that aorta that goes to the heart because your heart needs blood and oxygen,
Mm-hmm.
right?
Mm-hmm.
It needs all of those things to keep it healthy.
Mm-hmm.
We worry about not being able to get blood supply to our extremities. But if those coronary arteries get blocked, who cares what's happening to our extremities? Because that heart won't function anymore. If the heart doesn't function, what happens?
You die.
You die. Right? There's no cool thing like for the diaphragm, right? So they learn C3, 4, and 5 keep you alive, right? Because we need our diaphragm to work. We need our heart to beat. And we need our lungs and diaphragm to work. Everything else we can manage. If we don't have those two things, what's the point?
Brain
Right.
to have oxygen, right?
What was that?
And brain to have oxygen.
The brain needs to have oxygen, but if the heart isn't working and your lungs aren't working properly, then your brain isn't going to get oxygen either, right?
Okay.
Like that's our motor control center, so we want to worry about that. But that depends on the other two, right? So those coronary arteries, if they're blocked, they open up that chest and they do that bypass, right? So they attach an artery to before where that blockage is, and then they go around it. That's your bypass. I read somewhere, who had 5? Someone told me that somebody had 5. Oh my goodness, no, it wasn't him, never mind. But someone said 5, they had a 5 coronary artery like bypass. I was like, what?
Wow.
I kind of walked in right when I was gonna tell y'all, we start cardiovascular in Patho today. So Dr. Harry has a clinical seminar from 1 to 2. Then, y'all have a break. I'm not gonna lecture from 2 to 3, okay? But I'll record the lecture. So you can watch it recorded if you want to. It's very simple, it's just PowerPoint.
Jake, are these patients usually in before they undergo their cabbage? They can be very deconditioned. So they're already weak. They can be overweight, right? So they've got a lot of these other things that will make simple moving difficult, right? Because you're like, oh yeah, like you just lean forward and stand up. Oh yeah, that's simple for us. But if you've been dealing with somebody who is deconditioned and maybe they've known they've had some coronary blockage for a while, but it wasn't really severe where they really needed surgery at that time, and they tried to manage it with cholesterol meds and other things, then you're dealing with something more than just surgery, okay? Same thing with some of your orthopedic surgery, you guys. Like I think we talked about it a little bit last week when we went over that PBL. Unless it's traumatic, you may be dealing with issues leading up to whatever surgical procedure they have. So you're dealing with acute effects from surgery, but you may be dealing with chronic issues that led up to that surgical procedure. Does that make sense? So you kind of have to think about that. Most of the time we want to think about, okay, acute stuff. This is what's happening now. How do I get through this? But if they're in your care for long enough, you've got to start to think about, okay, this is what you were doing before, now we've got to change this, okay? If you've listened to those cardiac rehab lectures, you know more than anything, education is big when it comes to cardiac rehab because they have to learn how to change their lifestyles. They have to make all of these modifications that led them there. It's not just physical, it's overhauling everything they've done. Everything that they were taught when they were a little kid about what's good to eat and what's not good to eat, and you live in the South. You guys live in the South.
Right.
We are not known for healthy food in the South. Okay? So it's one of those things, like everything needs to be fried. Well, of course we're all going to end up with heart disease. Okay? So it's a lot of education, and that's important there. When they get into those later stages of cardiac rehab, then you're now pushing, let's exercise. Now we're going to take care of this, because if you're understanding how to change what's happening at home, now you can understand how important exercise and movement is, and fitness is, right? Same thing with your pulmonary patients, but it's not quite as intensive, okay? When they go to pulmonary rehab, they are trying to do all of the aerobic exercises just like we kind of talked about with cardiac patients. They don't have as many precautions because their heart hopefully is fine. Unless they have the double whammy of CHF and COPD. Okay? Which is like every home health patient. Okay? And dialysis. Yes. CHF, dialysis, then you got to deal with dialysis and the effects of dialysis, right? Okay, does that make sense? I don't know, how did we get off on this topic anyways? Oh, it was coughing and huffing, okay? So when you go back, let's circle back. Let's draw myself back in, right? So when you're teaching a patient to huff, it's like you want to fog up that mirror, okay? It doesn't have to be because you may be engaging too much abs. Okay? When you cough or you engage a lot of your abs, you guys will constrict your bronchioles. Now we see a problem, don't we? Because what is the purpose of what have we just been doing all morning? To get it out of the bronchioles. So another thing is, if they are struggling with a cough or you want them to cough, there's potential that you may close those bronchial tubes. If you're closing the bronchial tubes, what's coming out? Nothing. Blood, maybe, because you're working so hard. You're having to push something out, right? What is the Valsalva? What's the Valsalva maneuver?
This is where you pop your ears.
Kind of, but how do you do it? What do you do?
Holding your breath and blowing.
Yes, that's it. You hold your breath. You don't necessarily have to plug, but you just hold your breath, because if you don't plug your nose, then you may still like breathe through your nose, right? But basically you're holding your breath, right? Okay? So with all of these patients, you don't want them to do a Valsalva, because again, you're closing everything. For my patients that have constipation, you guys, this is one of my favorite things about bowel dysfunction, okay? Is when I tell someone who's in their 50s that they've been pooping wrong for 50 years, right? And they're like, what? Right? Because you're not supposed to push, right? So, I mean, like, I can tell my son is really, he's hilarious, you guys. He gets on all fours, and he kind of will sit there, and you'll see him, and he'll go, on all fours, and I'm like, oh man, Landon's pooping. Yes, this is my 2-year-old, right? And I'm like, man, I was like, he's pooping, and I can see him across the room because he gets real still, and he'll get into like all fours, and he'll get real still, and I was like, oh man, he's pooping. I was like, do I try to change a diaper real fast, you know, right? Because I can see it, but what he's doing is he's holding his breath to try to create that pressure to push the poop out. Okay, now if you're dealing with constipation and like pelvic outlet disorders, when you do that Valsalva, you're contracting the muscles around the rectum. So you're closing the opening that you are trying to push the poop out of. Where is it gonna go? Not out, right? So if you're sitting on the toilet straining to get poop out and you start to feel everything in your head and neck, the pressure has to go somewhere. You've closed the opening you're trying to push something out of, that pressure will go somewhere.
in your head, right?
Not out. You can get hernias, you can get hemorrhoids, you may get headaches because the pressure is coming up, right? Think of cartoons when the pressure in that boiler gets really, really high and it's just gonna pop. It'll find someplace to pop and you may not know where it is. Okay?
Squatty potty, do you approve of the squatty potty?
I totally approve of the squatty potty.
What is that?
It's a little stool. It's a little stool that sits around the toilet so that you put your feet on it and so that basically you're squatting over your toilet.
I
basically.
have
You're
one.
supposed to poop. The toilet set us up for failure.
It did.
Yeah.
You know,
The
we
toilet's
think we're more
designed wrong.
advanced, but
Well, Sawyer, what he does now, like he'll dip his butt so low it hits the water and he's just hanging on it.
Hanging
He's
on?
Just in there, I'm like, whatever it is, whatever you don't fall in.
clean it good.
He holds his shirt
right?
in his mouth. and
But if
pulls
you
out
look,
in there.
you guys probably won't ever look at this, but this is really interesting to me. When you look at pelvic organ prolapses, constipation rates, like in the U.S. compared to Asian nations, African nations, it's ridiculous. It's ridiculous because we sit on the toilet and we do horrible things to our bodies to cause all of these dysfunctions. They swat.
But just the position of the pooping is bad.
Because if you eat vegetables, the poop comes out a little bit
But
better.
even still,
That's true
I'm just here to
too.
tell you.
Our diet is just horrible.
That's why I'm a
But the toilet doesn't help. If you don't know how you're supposed to sit on the toilet either.
Our society doesn't
It
make
literally
time to sit
pictures,
and eat.
right? Like, if you're at a 90 degree, which is up the toilet,
But
then
they
the
don't-
squatty potty opens that.
So the squatty potty opens up that pelvic outlet.
The fact that someone purchased that is just.
but
No,
it makes
I have
sense.
one.
I should have created it and I would be a millionaire.
It makes sense though, because I mean that's how your body is
I have
designed.
one. My husband wanted it. I don't use it, but he.
You should use it.
Always have like
But listen, I don't have one, but I mimic the position that I know what position I should be in when I poop. And so that's what I do.
I knew what mine was on Christmas.
And the other thing too, right? So now, even with the squatty potty, like, so we've gotten way off topic, but even with the squatty potty, you guys, you're in the right position. But if you're still doing the Valsalva, you're still screwed.
Yeah.
You are still screwed. Okay? So you have to exhale as you push. And that poop will come right out.
Oh, wait a minute. Okay. The Valsalva, I'm making sure I'm clear on Valsalva. So, what you're doing is holding your breath.
I'm taking, because listen, I still want to engage my abs to give that push,
Okay.
but I'm not holding my breath
Okay.
to try to contract my abs and get my
Okay.
abs to work.
Give
Right.
it pressure.
Okay? I take a breath in,
Not going-
and then it's a resisted blow. Do you feel your abs engage?
But it's kind of like if you do like a heavy lift, you're gonna take a deep breath in and hold it.
No,
and then release.
as opposed to.
I've never blown out and then tried to lift
And I'm like, oh.
So take my breath in.
But you're exhaling as you do your lift. You're supposed to exhale as you lift.
Oh, it's okay, maybe push it in.
But to get it up, like.
Yes.
It's only 30 days up.
So if you do it a lot and a lot and a lot, I would watch your pelvic organs.
That's how Elvis died.
I already told him my ankle was.
I would watch pelvic organs.
I've always heard.
Right? You don't feel your abs engage when you do that?
Not as much. So I go in.
But you don't, here's the thing, you don't need, this is what it is. People think because from a young age, like my son, from the beginning of him trying to learn how to poop, his go-to method is, I'm gonna hold my breath and I'm gonna make my face turn really red. That's how we are taught as kids that it's okay to poop.
Okay, but we don't actually teach kids to poop. They come out.
No, but they don't know how to do it. They don't know how to do it except they know they need their abs.
Get it out.
We are naturally inclined to say, I need my abs to contract to push my poop out.
I mean, like,
But you don't need to
hold your
force
breath
it
and,
because
like,
what's happening is as soon as he holds his breath, his pelvic floor muscles are contracting around the rectum. That puborectalis does and closes off that rectum. Where is the poop gonna go?
Just power
It's
down
not
in
coming
one spot.
out. And if they are able to force it out, then you may get rectal bleeding because you've torn things to try to push your poop out.
Hemorrhoids.
Let me tell you, like,
But
this
that's
is,
kind of how like they tell you to have a baby, like take a deep
yes,
breath.
Yes.
it's the same thing. It's
They tell
so
you-
awful. It's so awful. But
So you
that's the way
shouldn't
it's
do that
been
when you're having a
done
baby?
and done and done. And when I worked at that pelvic health center, that was one of the things that we tried so hard is to get into those OBGYN offices and say, stop doing that to these ladies.
So
You're
chin
tearing them
down,
apart.
when it's chin down, bear down, and You're not
Yes,
supposed to
you
do
hold
that.
your breath and you push. And what happens?
That's how I push
You
my
poop
own
and you
butt.
rip everything into shreds. Right?
I mean, I knew about it.
First baby.
See,
was
but
in
listen,
there.
you guys got me way off topic on something that obviously is.
But it's learning.
Like they're not.
It's learning.
OBGYNs don't.
It's not that they don't
Or
know,
that they don't tell
but
them.
they don't care. You know why?
They don't have to
Because
deal
that
with
position makes it easy for them to catch that baby. Because the women, right? Because when I go to classes, I can hook, or when I have a patient, when they're pregnant, I hook them up to biofeedback. And I say, okay, we're gonna try to get into this position and let's see what your muscles do. Don't contract, you just try to be as relaxed as possible and let me see what your muscles do. And then we try different positions to see where their pelvic floor muscle just naturally wants to relax for them. And I'm like, that's the position you should be in when you deliver your baby.
Yeah.
And if that means squatting on top of that bed,
Right.
then that's what they should do.
That's
But the
why
doctor's
other
like,
countries
no,
they
I
squat.
want you to lay down here, open wide, so I can catch like this.
Yeah. It's a position.
Because when that baby comes, they don't
Other
do
countries,
anything.
squat.
What do? They sit there with their hands out. And then as that head comes out, they grab that head. And then when you do that final push and that baby comes out, they're like, here you go. And then they hand it to the nurse. That's what your OB does. Unless they have to cut you open and do a C-section. They just got paid thousands of dollars to do nothing. And so that position is easy for them.
Everything's a scam.
Mhm. When Lauren was born, apparently the cord was wrapped around her head. So my husband was like, yeah, he just sat there, and when he could see the neck, he said he took his pinky and did this, and then like, there you go, and then he's out. And then the nurses are there cleaning up,
You
and
gotta teach that.
you know, and I'm like, okay, that was it. He walked in with Lauren. He walked in, I was ready to push. We pushed for like 10 minutes, and then he walked out.
Yep.
So it's easy for them. Not easy for the lady.
I got slush, so I need
One
to
thing
know.
that helped once her water broke, she
Mhm.
would maybe be there 15 minutes.
15 minutes, so
After
she just sat in the tub?
Call the EMTs.
Yeah.
Come deliver the baby.
Right? I mean, like, it's really crazy. So we got way off topic. Way off
So,
topic.
like, how does smoking mess up, like, how you're supposed to get out, like, all the mucus and stuff? Like, doesn't it kill part of, or, like, sedates it, I guess, I should say?
I don't know if it does that, but you know, it'll leave like the tar and the residue, which will close off your the bronchioles, right?
Like, if
So
you
it
already,
narrows
like-
narrows the thing, but then it's not going to release as easily as if it was like mucus or secretion.
Kind of clog it up.
Same thing
And
with
the
like
oxygen
COPD
level.
makes it harder, or that's just more like their
Smoking is like you gotta
That's
let it
weird.
drain. It drains not.
See, but like with COPD, there may not necessarily be something inside the tubes that are doing it. They are just constricting.
Same thing with asthma.
So it's a responsive thing, and those bronchioles will restrict, not allowing the air to move.
All you do is just
Okay. Do you guys have any questions? We got way off topic, you guys. I'm sorry.
But it's helpful because it's like you're thinking.
Yeah.
Still education is we gotta know the whole body. Really.
Which I know, but we got off on bowel dysfunction.
You tell them to blow
Well, we have to go to the bathroom every day, so it's helpful.
So like if I'm trying to teach a kid how to like go to the bathroom, like if you teach them to like blow bubbles, because it's that same thing.
It really helps.
So for your pulmonary patients, let's go back to breathing and your pulmonary patients. This would be like on your sheet where it says breathing exercises, pursed-lipped breathing. So you purse their lips and then you try to blow that air out. It can be used to calm them down and bring down that respiratory rate. Okay? Okay? And then here's my thing about diaphragmatic breathing. Okay, so when you read through the thing, it says you're going to put your non-dominant hand on your ribs, and then like your dominant hand on your belly, and like as you breathe in, you should kind of see belly move and things like that, right? But if you really watch how your diaphragm works, it's not so much that we're getting a belly bulge with diaphragmatic breathing. We're getting rib expansion, okay? So when people are like, oh yeah, you're gonna breathe and expand your belly, and I'm like, ah, makes me wanna hit somebody, okay? Because it's so wrong. That's not what your diaphragm does. As your diaphragm contracts and like depresses, or it's gonna contract and like come up, your ribs are expanding out, right? You're expanding out. We're not.
I've been told to breathe like that for
What's this?
dance, but then for band when we did breathing exercises, it was belly out, and it always confused me.
So it's not
back
belly
and
out?
forth between the two.
Not
It's
necessarily, not
ribs.
all.
It's ribs
Because
out.
it's your ribs. I want ribs to move because that's what is attached to, or the diaphragm is attached to the ribs. When you watch videos on how that diaphragm works, it's pulling those ribs down and out. Down and out. Okay? You're going to get some belly movement because you're changing pressures, but you're not teaching somebody to like, you can't even do it.
It's actually, yeah.
Right? So like what I look for is I want rib expansion down here, just a little bit up here. Why do I want just a little bit up here and more down here? Well, yes, the diaphragm is down here, but why? What's the shape of our lungs?
They're bigger.
They're bigger at the bottom. So if my ribs are expanding down here, I am getting more air into the lungs where more of my alveoli are concentrated. Okay? If I'm only breathing up here into my upper lobes,
Shallow breathing, and then
it's very shallow breathing. These are your COPD patients, you guys. Their diaphragms may not be working, so what muscles am I using to try to move my rib cage?
Your neck muscles.
Scalenes, traps. Sometimes you might engage lats because of where they're attached, okay? If you go to the last page, of that handout I gave you this morning. You can use pecs. If you're not moving your arms, if you hold your arms steady, now you're moving what we think of as our origin of our pecs. If I'm not moving my arms. When people are really out of breath, why do we hold our hands like this on our heads? Because we're trying to stabilize our arms so the other sites that are attached to our ribs are moving our ribs. When I'm tired, I do this, right? Because I'm trying to stabilize my arms so that when my pecs contract, I'm not doing horizontal abduction. I'm trying to pull my ribs apart so I can get air into my lungs. If I'm holding my hands like this, I'm stabilizing my shoulders so my lats can pull my ribs apart to allow air into my lungs.
Another myth with growing up playing sports, the coaches would get on to you
For doing that, because it makes you look weak. No, I'm trying to get air in my lungs.
No air down there.
Right? Does that make sense? So when you guys look at this picture, these are all of our accessory muscles for breathing. What's our primary respiratory muscle? Diaphragm. All of these are our accessory muscles. Okay? If your diaphragm doesn't work well, you will be compensating with all of these. Your COPD patients, you'll see them, and you can see their scalenes working to try to pull up on those ribs. What'd you say?
Hyperhernia, that's when you have a hole in your diaphragm, and that makes it harder. But they don't ever repair them, rarely.
I don't think so.
Yeah.
Right? Okay?
It's the diaphragm does not like you break it, you break.
Pretty much.
How do you break it? How would you break it?
It would be like trauma. I would think either like gunshot, knife, stab wounds, a fall.
What about people who are paralyzed?
Well, so if they're paralyzed, depending on where they're paralyzed, it's not a direct injury to the diaphragm. It would be the nerve roots going to it, right? So if you have a spinal cord patient, and we'll get into this in the summer more, but if you have a spinal cord patient that's a C5 level, they may still have some function of their diaphragm because 3, 4, and 5 innervate the diaphragm.
Keeps you alive.
That's right. S234 keeps the P off the floor. Okay? So you guys won't ever remember or forget that. It's really bladder and like rectum.
We need all the help
It's
we can
easier
get.
just to say P off
All
the
the help
floor.
we can get.
Right? So, like, yes, like, you know, all of those things. Okay? Does that help?
Yeah.
I don't know what else is in your lectures.
So basically then your option is just a trach. If your diaphragm.
If the diaphragm isn't working.
Is that reason like why people get trachs there too? Like cerebral palsy, like why they have a trach?
It could be because depending on how their CP is affecting them and what might be like spasmodic, then they may not be able to control that diaphragm, and so they may need help. But if you can restore diaphragm through intervention, exercise, in the summer we talk about how to help facilitate diaphragm in like spinal cord patients. So, so if they have like a C4 level, you may still be able to get some diaphragm use, and there are some techniques to try to help like facilitate the diaphragm to contract. I don't think it's in this one. It might be with the spinal cord. Oh yeah, no, it's here too, right? So it says, if you apply firm counter pressure over the patient's dominant hand just before instructing the patient to inhale, what you're trying to do is you're facilitating that diaphragm to contract. Okay? You're doing like a quick stretch to that diaphragm. So there it is. It is there. Okay? So it's like they exhale, they're exhaling. Okay? So if their hands are on there, you've got your hand on their dominant hand, they're going to exhale. Right before they inhale, you do a quick pressure.
Is that the old G. Clinton organs that do, the muscle spindles? Which one is it that's like where it's like?
I think it's a muscle spindle. It's the muscle spindles because you're trying to get the contraction.
That's right.
So you're doing a quick stretch to get that contraction,
Is the
that
stretch reflex?
responsive. What was that?
Stretch reflex?
Yes, but you're engaging like the muscle spindles, right? So you do a quick stretch, and then it's a quick like overstretch, and then those muscle spindles will respond, right? So it's like the response is the contraction, which is what you're wanting. So if they're struggling with getting that diaphragm, you can do the quick stretch. It's going to facilitate the contraction to help get them a better contraction in that diaphragm. Okay. Any questions? Concerns? Okay, so tomorrow we're starting resistance. Okay, module 6.
Oh, tomorrow Thursday, okay.
It'll be really easy tomorrow. I am in no way expecting you guys to get through module 5 and then to listen to module 6 before tomorrow. Okay, it's not my expectation, so please don't freak out. Is this cardiac? So, to me, the cardiac module is harder than the pulmonary module.
Oh, yeah.
Okay.
Yeah, it was a lot.
There's a
That
lot.
first video had me like,
There's
30
a
minutes
lot
talking about-
happening in that cardiac one. Okay, because you've got the cardiac rehab part, then you've got the aerobic exercise part, and then you've got the part about ECGs and trying to understand what you're looking at.
Is our
Okay?
test gonna be on all three?
Your test is on cardiac and pulmonary, so you'll have components of everything. Okay?
and 25 questions.
Yes. Okay.
We're gonna need a percentage on that one.
Well, I can tell already there won't be a lot of like ECG questions per se. You're definitely going to need to understand cardiac rehab and goals and phases of cardiac rehab for sure. You kind of are going to have to know how aerobic exercise affects all the things that are talked about in that PowerPoint. Like it's
like on like the anatomy of the heart, like a lot on that. I understand knowing the anatomy of the lungs.
Look at the PowerPoint.
Yeah, there's a
but
lot.
Yeah, I know.
but the thing, like at this point, the anatomy should be a review.
Okay.
So if it's totally strange to you, like you need to understand it.
Right.
Am I gonna ask you like
Which one?
give you well, there is a diagram on there. Because I do think it is on the coronary arteries, so there you go, there's your one hint about anatomy. But again, you want to know the coronary arteries because when you go through the ECG PowerPoint, those parts of the heart that are supplied by those coronary arteries are what you're looking for when you look at the ECG to understand where your heart attack is happening.
Is there a whole separate ECG?
Yes, ma'am.
See, I thought I went through the whole module and I didn't see it.
So there are 3 PowerPoints and like 6 lectures.
There's no
Oh, there are only
lecture.
4?
There's no lecture for ECG. There's
Oh,
a PowerPoint.
So it's supposed to be
no, there is one. So I will put it up.
Oh,
Darn.
oh boy.
Yes. So because I think I was really late in recording it because I wanted to try to learn it better, and then I was just
I
like,
saw it last night and I was like, oh, maybe ECG isn't like that.
No, so like understanding the anatomy is relevant because it helps you to understand what the heck is happening on those ECGs. I think it's about an hour.
Oh my gosh, it's like 4 hours of lecture for that.
Because it goes through, we talk about what normal,
The second 2 are.
and then we talk about arrhythmias, and then we talk about what you're looking for with MIs, and then we talk about pacemakers, and like, yes, right? So you have to understand when you look at an ECG, kind of like what's happening in the heart. So you have to understand, is it an arrhythmia you're looking at, or is this person having a heart attack? So you have to be able to kind of distinguish that. And then if they're having a heart attack, it's going to tell you where the infarct is happening, okay? So when you look at the leads on that 12 lead ECG, it'll help pinpoint what artery is having the dysfunction.
And your test is the week after next?
I believe it's the 23rd,
Not next week.
not next week.
This feels like
We have a
medical
test next
school.
week?
Just remember, you want us to go to Miss Walker's.
I do want you to go to clinic, but what I don't want you to do is end up at clinic and they be like,
Send you back.
Yeah. What is going on with you? You don't have to go back.
listen, I can't take it. That might be the thing that really makes me walk out the door, is if I hear back from a CI that my